Hello. So in this presentation, we'll be elaborating the different kind of red blood cells morphology that can be seen. So the size of a normal RBC is between 6.0 to 8.5 micrometer, and you can compare it with the size of the nucleus of a small lymphocyte. It is slightly smaller than it, and the edges are round and smooth. It is a very round cell with smooth contour, and it takes the eosin component of the Romanowsky stain. So if you see a slide of a peripheral blood smear, the ideal area to study the morphology of RBCs is the neck portion. This is the head area, this is the neck region, and this is the tail portion. So the junction between the two area, that is the neck region, is the ideal area. In the head portion, you will see a lot of overlapping and a lot of rouleau formation, and no morphology can be appreciated over here. So ideally what we should see is that there is no rouleau formation. The RBCs should be barely touching each other, and they should not be much overlap. A little overlap is allowed, but there should not be a lot of overlapping. And if you go on to the tail area to examine the RBCs, you will get a false impression of spherocytes. So if you compare these two images, these are the two images of the same slide. But this is a very different picture and this is a very different picture. So this is the portion of the head area where there is a lot of overlapping of the RBCs and we cannot actually comment on anything. And in this image, you can see that the RBCs are at times touching each other. At places, there is a minimal amount of overlap, but you can appreciate the morphology of the RBCs. And they're not even too sparsely distributed, so they will not give you any false impression. They are just adequately distributed in this area. So when we go on to listing the different causes that cause red cell abnormalities, we can categorize into these four categories. First is the bone marrow increases the erythropoiesis to compensate for anemia. This results into the less mature RBCs being present in the peripheral smear. That can be seen in the form of polychromasia or erythroblastemia. Or the other reason is inadequate hemoglobin synthesis, in which there is reduced to unequal hemoglobin content and concentration, that is hypochromasia, anisochromasia, or dimorphism. The next reason is abnormal erythropoiesis, in which we can see an increased variation of size, that is anisocytosis, or shape, that is poikilocytosis, or we can see basophilic stippling or dimorphism. And the last reason is the damage or alteration affecting the RBCs after leaving the bone marrow, including the various splenic defects. Here we see spherocytes, elliptocytes, ovulocytes, schistocytes, and presence of pypanemia bodies and many other abnormalities. So starting with abnormal erythropoiesis, first we can see because of this anisocytosis and poikilocytosis, that is variation in both size and shape. We'll be elaborating on these further. We see macrocytes, microcytes, and basophilic stippling. So what is anisocytosis and poikilocytosis? Anisocytosis is a variation in the size and poikilocytosis is variation in shape. In anisocytosis, we can either have microcytes or we have microcytes or we can have combination of both, or we can also have a combination of microcytes, macrocytes and normal RBCs. In microcytes, as we can understand from the name itself, the cells are smaller than the normal cells, and macrocytes, the cells are larger. And in poikilocytosis, there is a variation in shape. We'll be elaborating on the various kinds of shapes further. It can be seen in megaloblastic anemia, iron deficiency anemia, thalassemia, MDS, membrane defects, and many other causes. So in this slides, we can appreciate the macrocytes. So this is a macrocyte and this is a normal RBC. See, there is a variation in the shape. This is much larger than this, and so is this cell. So you can compare the size. So the size of the cells RBCs is more than the normal. It's commonly seen in megaloblastic anemia. It is also seen in aplastic anemia, MDS, and other dyserythropoietic states. But megaloblastic anemia is the more common cause. And in diseases which is caused because of excess alcohol intake, we can also see stomatocytes. What are stomatocytes? These are stomatocytes, in which you can see that in the center of the RBC there is a slit-like appearance. So in this we have macrocytes along with stomatocytes. It is also seen in conditions where there is the increased rate of erythropoiesis, in which the reticulocyte count is also increased. Further proceeding on to microcytes, the presence of microcytes, that is the size of the cells being smaller than the normal RBCs, it indicates a defect in the hemoglobin formation, characteristic of iron deficiency anemia. It can also be seen in thalassemia and anemia of chronic disease. And it is very important to differentiate schistocytes from microcytes. And even though the MCV is reduced, but the decrease in the MCV is not as much as seen in microcytosis, because not all RBCs fragmentation syndromes. So if you see in this image, this is, see, you can see a lot of microcytes. See, this is a normal cell and this is a smaller cell. See, similarly, this is a smaller cell, it's a microcyte, this is a microcyte. In this image also you can see this is an image of thalassemia. You can see a variable number of shapes and you can see a lot of microcytes being there. So further proceeding on to getting an understanding of basophilic stippling. Basophilic stippling is also known as punctate basophilia, in which in the RBCs you see multiple granules that have a basophilic color and they have a negative reaction for pearl stain, and pearl stain is put for ionized iron, and it is positive in case of Pappenheimer bodies. It indicates distributed erythropoiesis and not increased erythropoiesis. It is seen in case of thalassemia, most common, also seen in megaloblastic anemia, infections, liver diseases, and lead poisoning. So this is a case of a normal basophilic stippling, and this is a case, so basophilic stippling is not normal, but like seen in cases of thalassemia, megaloblastic anemia, infections, and other problems. And this is a case of basophilic stippling seen in case of lead poisoning. As you can see in this RBC, there is fine basophilic stippling. If you see very clear, very in a very focused manner, then you can observe this. And this RBC shows very coarse basophilic granules. If you compare these two, so you can see two types of basophilic stippling. One is more fine, one is more coarse. This is seen in lead poisoning. This is one feature that you need to remember. It can differentiate between the other pathological causes and lead poisoning. Another reason why we see abnormal shapes and sizes of RBCs is inadequate hemoglobin synthesis. Under this heading, we will be studying about hypochromasia, anisochromasia, and dimorphic red blood cell population. Proceeding on to hypochromia or hypochromasia. Hypochromasia means palely staining red blood cell. So, what gives color to an RBC is the hemoglobin. So, what is the most probable cause of a hypochromic cell? It's a lowered hemoglobin concentration. Where is it seen? It is seen most commonly in iron deficiency anemia or sideroblastic anemia and thalassemia. And the other reason is abnormal thinning of RBCs. Abnormal thin RBCs are called leptocytes. It is seen in cases of defect in hemoglobin synthesis, like in thalassemia and liver diseases. So, these are the two cases. The most common causes, one being iron deficiency anemia. So, this is small lymphocyte and this is a normal RBC. If you compare the size of the nucleus of a small lymphocyte to that of an RBC, you can realize that this is a normal RBC, and this and many others, they are abnormal hypochromic RBCs. Similarly, you can see the image of a patient of sideroblastic anemia and you see a dimorphic picture. Dimorphic picture showing normocytic normochromic cells along with hypochromic cells. So this is a normal cell, this is a normal cell, and then you can see cells with hypochromasia. So two types of populations of cells are existing in sideroblastic anemia, and this is a case of iron deficiency anemia. So now we know what is hypochromasia. Another topic we need to emphasize on is anisochromasia or dimorphic red cell population or unequal distribution of RBCs. So in cases, some but not all RBCs are hypochromic. See, this cell is relatively normal. This is hypochromic. This is hypochromic. This is also hypochromic. So two types of populations are seen. One is normochromic and the other is hypochromic. This is seen in a changing situation, like either as a patient is developing iron deficiency anemia or the patient is recovering from iron deficiency anemia. Other situations where it can also be seen is a patient being treated for megaloblastic anemia who further develops iron deficiency anemia, or in patients with post transfusion for iron deficiency anemia, or also in cases of sideroblastic anemia. In acquired sideroblastic anemia and in MDS, we see microcytic hypochromic and normocytic hyperchromic cells coexist. Normally, it's very difficult to find normocytic hyperchromic cells, right? So, see, this is one point that is out of the ordinary.